There's Eric.
Hi, Chris. So, Sia, I will soon join you. Welcome to our neighborhood.
Good to see you. Thank you. So great to see you.
So I see we have a quorum online, Zia, and I'd like just to give a brief introduction, if that's okay. Zia is the Julius Stoll Professor and Chair, Department of Neurosurgery at the Warren Alpert Medical School at Brown, as everyone here I think knows. And he's the neurosurgeon chief at Rhode Island Hospital and Miriam Hospital. So really right in our neighborhood, and a great addition to the New England neurosurgical people that are here. Ziya is originally from Turkey and then came to the United States and was at Baylor and in Houston, very successful spinal oncology practice. Went to Hopkins, as everyone knows, for a number of years. And then Brown was lucky enough to recruit him as chair 6 years ago, where he's grown the program from 6 residents, or from 6 to 16 faculty in 6 years, which is impressive. He's the recipient of many awards, and I won't list them because we want to hear his lecture. So without further ado, I'd like to introduce Ziya, who will talk to us about spinal neoplasms, which we've become internationally known for. So Ziya, please.
Well, thank you so much, Chris, and it's so great to see you all here. And thanks for dialing in so early in the morning. And so this is something that I had focused over the last 30 years during my entire career. It all started at MD Anderson Cancer Center. Also, we accumulated a substantial amount of experience. So I have also had the privilege of seeing how the field has evolved within the last 3 decades, which really has been a phenomenal transformation. Let's see if we can advance these slides. We just looked at our experience this past year. We passed 5,000 number in terms of the surgical cases that we've done in patients with spinal tumors. So the point of this slide is about 90% of the cases are metastatic tumors, and about 10% of them are primary tumors, and we've used all sorts of approaches in treating these tumors. The cancer field has transformed dramatically over the last several decades. I mean, just to show you a couple of examples here, this is the classification of the tumor based on genomic profile, and you can see there are 3 different types of tumors here: endometrial CA, ovarian CA, and breast CA. They are very similar genomically, and a majority of these tumors are also treated similarly, despite the fact that they come from 3 different organs. This is just showing some of the discoveries within the last several decades. This is related to the systemic treatment of melanoma, and you can see here a single mutation was identified in some patients with melanoma, and when you target that mutation, as was the case in this patient with widely metastatic melanoma, you can see that the tumor responded dramatically, and many of these responses are quite durable. As you know, our president is also being treated in a similar fashion and has been around almost 7 or 8 years now with brain metastases from melanoma. So dramatic transformation. Most recently, of course, checkpoint inhibitors came into play. That really had a huge impact. When I was at MD Anderson Cancer Center, typical lung cancer patients with metastatic disease of spine would die within literally 4 months. And if you look at even this sort of the publication in New York Times, which was picked up, as you can see, the median survival of stage 4 metastatic lung cancer with checkpoint inhibitors can be close to 2.5 years now. So it is quite dramatic that the field has evolved substantially. I just want to start with a case example here to set the stage, and maybe have our trainees to think critically about evaluating patients with various types of spinal tumors. Here's a patient who's 50 years of age, otherwise healthy, presents with about 3-month history of thoracic radicular pain. On examination, she's got mild lower extremity weakness in the iliopsoas muscle and mild gait impairment, some early signs of thoracic myelopathy. And you can see the patient's MRI scan in the mid-thoracic region. There was a lesion that's taking up the majority of the vertebral body, extending to the left pedicle, which explains the left side of radiculopathy. So what do we really do with this patient? First, this patient has no history of cancer, no malignancy. Of course, typically we would do a systemic workup, but the answer really lies in the biopsy of the lesion in most cases. So we do a CT-guided biopsy, and I just put 4 hypothetical diagnoses here just to stimulate the thought process here. And let's say that the patient comes back with a diagnosis of a lymphoma. That patient would not require surgical treatment, right? This patient will probably go to straight chemotherapy in our institution. If the patient comes back with diagnosis of breast cancer, probably the patient will go to conventional radiation treatment. If the patient comes back with a diagnosis of renal cell carcinoma, we would probably treat that patient surgically after pre-op embolization and do some sort of separation surgery to optimize the results of the stereotactic surgery. And if the patient comes back with a diagnosis of a chordoma, then we would think about something more complete in terms of the surgical treatment. But just to give you a sense of how the initial diagnosis based on the biopsy dictates what needs to be done, anywhere from no treatment, no surgical treatment, to all the way, most aggressive surgical treatment, depending upon what tumor that we are dealing with and how we are combining other modalities in managing this patient. This is a very old slide. When I was at MD Anderson, we put this together based on the experience there. These are sort of the median survivals of the patients when they present with metastatic disease to the spine from these primary tumors. You can see on the left side, those are all listed. As I said, the things have changed dramatically for lung cancer. The same is true for melanoma, as I've shown you before. And renal cell carcinoma has also gone through a very significant evolution with now, the VEGF inhibitors and many other immune checkpoint inhibitors that are being tried for that. So the field has changed substantially, but nevertheless, as soon as we know what kind of tumor we are dealing with, we have a pretty good sense of how long this patient is going to live based on the histology of the tumor. We also know immediately how the tumor would respond to the conventional radiation treatment. You can see sort of the tumors that are put into 3 different buckets here, very sensitive, or not sensitive. And so the tumors that are in the sensitive category would be treated non-surgically, as I indicated before. And the ones that are not sensitive most likely would require some sort of a surgical intervention. And so we get a sense of how the tumor would respond to both conventional radiation therapy as well as chemotherapy, just based on the histology of the tumor. We also know if the tumor is vascular, that something else needs to be done before the surgical procedure. We do know that, of course, the renal cell carcinoma is the obvious sort of the prototype of a vascular tumor, but other primary tumor, other organs of origin, for example, thyroid, hepatocellular, CF, pheochromocytoma, all of these tumors can be quite vascular. You need to think about embolizing these tumors before taking out the patient to the operating room. The melanomas and myelomas tend to also be quite vascular, but they are difficult to embolize in many cases. And so you need to be prepared to give a lot of blood transfusion in those cases. The point here is that as soon as you know the histology of the tumor metastatic to the spine, you also get a good sense of whether or not the embolization is needed in that case. We have a plethora of options in treating patients with metastatic disease. And how do we choose one versus the other? Which one is the most suitable treatment for a given patient? And this, can see a variety of options that we have in treating patients with spinal tumors. We typically use the NOMS framework. This really takes into account 4 factors: the patient's neurological status. We talked about the primary tumor type, which is the most important thing that you need to know for a variety of reasons. The stability of the spine, whether the spine is stable mechanically, is very important, because that really dictates, doesn't matter what kind of tumor it is. If the patient has an unstable spine, that typically requires a surgical intervention or some sort of a stabilization procedure. And then, of course, the systemic extent of the disease is a factor. How sick the patient is, whether the patient is going to be able to tolerate any given surgical procedure, and that may dictate what needs to be done with that patient. We recently, of course, also incorporated the genomic profiling and molecular profiling of these tumors because they tend to dictate what the treatment options are going to be after our surgical treatment, whether or not the lung cancer, EGFR positive or not, AKT positive or not. All of these things would play into the overall prognosis of the patient. We also talked about that, whether or not the patient has neurological compromise is an important factor. So one of the ways to assess that is how much spinal cord compression does the patient have. And we typically use the spinal oncology study group grading system that was generated for that. You can see in broad categories, the tumor is really either not touching the spinal cord or touching and displacing it, or into the subarachnoid space. And that really has implications how you're going to take advantage of the radiation treatment. I'll show you some case examples to illustrate that. And the spinal instability, whether or not the spine stable, is assessed typically using the spine instability in a plastic scale. Again, this is the work that I've done and many others did with spinal oncology study group, and we came up with this classification system to get a sense how stable the spine is. The spinal stability is different than in the setting of cancer compared to trauma setting, because in the trauma cases, typically the ligaments are disrupted or the patient has fractures of the bone, etc. Whereas in the cancer setting, primary mode of failure tends to be vertebral body collapse and axial loading type of injury. And all of that really makes the assessment different for cancer patients. And then I think it's important to look at how the treatment in general has evolved over the last several decades, because I think we have learned significant lessons from that experience. Originally, all of the patients were treated with conventional radiation therapy. If you look at the results on the right side, sort of the combined results, overall improvement rate when the patients presented with epidural spinal cord compression, as far as the motor function was concerned, was about 25%, 27%. Only a quarter of the patients got better. The others really did continue to deteriorate over time. And then the surgeons thought that maybe I can do a laminectomy operation, get some decompression of the spinal cord, and improve those results. And that, in retrospect, proved to be a flawed thinking, because the laminectomy is not really the proper operation to do in the setting of metastatic disease, in which the tumor is 80% of the time located in the vertebral body. And second, when you do the laminectomy, you destabilize the spine, and that leads to additional problems in a situation where the spine may already be compromised with metastatic disease and vertebral body involvement. But I would say that the surgeons, I think, wised up later and realized that maybe if you approach the spine from posteriorly, it may be a good idea to also stabilize the spine at the same time, and also get more extensile exposure of the ventral compartment and decompress the spinal cord more effectively. And you can see overall motor improvement went up substantially in patients with epidural cord compression. And then also, we first time in the literature started talking about significant improvement of pain in cancer patients with metastatic disease. And then finally, the surgeons have gotten much more comfortable with anterior approaches to the spinal column. And you can see here vertebral body resection combined with stabilization offered very substantial improvement as it related to the motor function, as well as, again, the pain was very effectively controlled. And so if you look at this 30 years of experience, how the treatment has evolved, what really have we learned? We learned that the laminectomy is not really the right operation to do in the setting of metastatic disease. Number two, we learned that the spinal stabilization is an integral part of any metastatic tumor operation, and in many cases the pain is related to spinal instability. We also learned that more effectively you decompress the spinal cord, the better the neurological outcome is. But all of this is, of course, retrospective data, and when you present this to medical oncologists and radiation oncologists, they typically say, your surgeons are cherry pick your patients. This doesn't really apply to an average patient that walks into my office at 4 o'clock in the afternoon on a Friday. I have to make that decision, and that brings us this prospective randomized trial that was designed by Roy Patchell, and this is almost a little over 15 years old. This paper was later published in Lancet, as you can see here. There was only one question asked in this trial: whether or not the surgical treatment in patients with metastatic disease offered any benefit over conventional radiation therapy. And this is a landmark paper in many ways, because it was a first prospective randomized trial and level 1 evidence that we had in the literature related to that. And then the study excluded all the radiation-sensitive tumors, the lymphoma, multiple myeloma, seminomas, etc. All were taken out. but we are looking at primarily the solid tumors that are relatively radiation resistant tumors. And you can see that the survival was dramatically different. The maintenance of ambulation was dramatically different between the patients who had surgery plus conventional radiation therapy compared to radiation therapy alone. And this was true whether or not the patients presented to the emergency room with neurological dysfunction, and surgery made, again, a dramatic difference. The patients maintained their bowel and bladder control longer, and they even lived longer, which is an interesting observation because patients were able to maintain their functional status and hence continue to be treated by the medical oncologist and radiation oncologist, whereas when the patient becomes paraplegic, they typically are sent to hospice to die. And so in all domains, the surgical treatment proved to be highly effective in maintaining ambulation, bowel and bladder control, even had an impact on survival. So this pretty much sealed the question related to the role of surgery in treating patients with metastatic disease. Of course, the radiation treatment that's used here is conventional radiation therapy. We're not talking about stereotactic radiosurgery, and this came into play later, as you can see here, had a huge, dramatic impact in treating patients with metastatic disease. We could control the tumors now highly effectively because we are giving very focused radiation, sparing the spinal cord, very high dose radiation. And then again, the pain was very effectively controlled in these patients. And this was even true for patients with renal cell carcinoma, for example, that is known to be a highly radio-resistant tumor by conventional radiation therapy standards, yet the tumors have really responded very nicely, but yet, this was not a panacea. Some of the patients really failed the treatment and requiring open surgical procedure. And if you look at those cases, this paper is an interesting one from MD Anderson Cancer Center. They treated all these 55 patients here with initially stereotactic radiosurgery with the renal cell metastasis, and 12 patients, over 12 out of 55 failed and required an open surgical procedure. When you look at critically what happened, these patients had tumor that was making contact with the spinal cord, and hence the dose was reduced to protect the spinal cord in that area, and that's exactly where they got recurrences requiring later surgical treatment. So this really clearly demonstrated that we need to find a way to address that before sending the patient to stereotactic surgery. And this brings us to this paper that was published from Bilski's group from Sloan Kettering. Ilya Lawfer was one of our fellows who wrote this with Mark, and they looked at their experience in treating patients with metastatic epidural cord compression. They realized that you have to give really a high dose of radiation. In this instance, you can see 24 gray in single fraction, and B, they noted that if you can separate the spinal cord from the tumor, then you can really have a great tumor control at the end without significant failures. In this instance, it was about 4%. I think the patients have failed. So this brought into the concept of separation surgery into the mix now, that in these types of tumors, typically you would do separation surgery and then send the patient to stereotactic surgery afterwards. This is a patient you can see with significant cardiac compression, and the patient had a limited operation done from posteriorly, separating the neural elements, and the rest can be addressed with stereotactic radiosurgery. So this is a simplified algorithm in my mind, but I think that it works well in most situations. Nothing is perfect. So I think that we have to really ask typically 3 questions in this order, and then choose the treatment accordingly. And the first question that we typically ask, whether or not the spine is stable. If the spine is unstable, it doesn't really matter what the histology of the tumors, etc. The patient is going to require some stabilization procedure. That doesn't necessarily mean an open operation. It could be percutaneous screws, it could be vertebroplasty, kyphoplasty, something along those lines where the patient needs, as the first intervention, is some sort of a stabilization procedure. The second question typically I ask is the tumor sensitive to a conventional external beam radiation? If the answer is yes, most of the time the patient is probably going to be sent to radiation treatment, unless the patient has such a profound neurological deficit that something needs to be done to address that. And then the third question, in that order, we are asking the question, is the spine stable? Is the tumor sensitive to conventional external beam radiation therapy? And if the answer is no to all the first two, then you're coming down to third, is the epidural tumor making contact with the spinal cord? If the answer is yes, then typically we take the patient to the OR to do separation surgery and stabilization, and the patient then is sent to stereotactic surgery afterwards to treat the disease. So if you ask these three questions in the sequential order, and then you can really get your treatment answers pretty reliably in most situations. I'm going to go and shift gears here a little bit, show you some of the primary tumors as well. And also, I wanted to highlight how we approach these tumors differently when we encounter them. I think from that perspective, it will be valuable. This is the general list of the primary tumors that we see in the spinal column. These are listed from the most benign categories to the most malignant ones. The ones that are highlighted in yellow, I would call them primarily medical entities, meaning that the greatest impact in survival in these patients had to do with multimodality chemotherapy, although surgery still plays a significant role in treating these tumors and resecting the mass. Whereas in setting of chordoma and chondrosarcoma, the primary mode of treatment is really surgical, because the other modalities typically do not really work very well. And the tumors that have asterisks next to them are highly vascular tumors. And not only do we need to think about pre-op embolization if you are doing surgery for these patients, but also sometimes the repeated embolization can be used as a therapeutic modality in managing some of these tumors. Now, it's difficult for anybody to accumulate a lot of experience to get a sense of how these tumors behave, whether or not any given type of surgical treatment really can make a difference. To address this issue, we work with the AO Spine Tumor Knowledge Forum. The collected data from multiple institutions, both in the US as well as around the world. And these are highly specialized centers that do a lot of primary spinal column tumors. And you can see we were able to extract from that data almost 1,500 patients. We also all have very detailed surgical information, very detailed follow-up in these patients, typically for many years. And so you can really get a lot of very good information from this. And as you can see, we collected a lot of chordoma patients, mobile spine chordoma patients. And then we asked one question here is whether or not, if you were to excise a tumor completely with negative margins, what we call an annealing appropriate procedure, if you were able to achieve that, would that make a difference in survival? And you can see that there's a dramatic difference in survival between those who had appropriate surgical procedure versus those who had contaminated margins. And the same is true when it comes to first time to recurrence. The patients who had surgery took much longer to get a recurrence as compared to those who had what we call intralesional resection. This is my experience looking at my own data from Johns Hopkins when I was there for many years. We treated all patients with sacral tumors that came in there with sacral chordomas with the intent to get a negative margin. And so we operated on them. As you can see, most of the time we were able to get a negative margin. And the patients did very well when we got a negative margin. If the patients got a positive margin, they typically had, started getting recurrences and dying relatively quickly. And so coming back to how we approach the patients with metastatic tumors versus those with primary tumors, particularly with chordomas and chondrosarcomas, these are sort of the practical take-home messages from that. If you're dealing with a patient with metastatic tumor, our goal really is to effectively palliate the patient, address their pain or neurological compromise. And typically, the surgical technique that we use if we're going to operate on that patient would be an intralesional resection of the tumor. Whereas if we are dealing with primary tumors, particularly for chordomas and chondrosarcomas, our goal is really to cure that patient or achieve a long-term survival. And in order to do that, typically the surgical procedure that we do would be what we call an en bloc resection of the tumor with negative margins, try to get the tumor out in one piece whenever possible. This is looking at our primary spinal column tumor en bloc resection experience, and you can see that the bulk of the tumors are chordomas. The second big category is sarcomas, chondrosarcomas, but the bulk of them are various types of sarcomas. And then we have some other less aggressive tumors that are also treated with complete resection. Occasionally, we do en bloc resection for metastatic tumors. These are typically renal cell cancer patients who had a local recurrence and they have no evidence of systemic disease. Now, let me show you some case examples to bring some of these points home. Here's a patient with metastatic breast cancer that comes to the emergency room with a severe mechanical neck pain. And this is a CT that was done in the ER. You can see the destructive lesion involving C2. The patient has fairly concerning craniocervical junction deformity here as a result of this. This patient is in severe pain, holding her head up with her hands in the emergency room. The patient's MRI is also concerning, although interestingly enough, the patient does not really have any significant neurological deficit on examination. So in this instance, we take the patient to the OR, and this is really a deformity operation and realigning the patient's craniocervical junction. So we take advantage of the modern instrumentation, occipital fixation, and then we use a technique actually we developed in treating patients with basilar invagination. Here you can see that in the case of basilar invagination, we try to extract the dens out of the foramen magnum and realign the spine. And so in order to do that, you basically apply a distractive force in the operating room after the exposure to distract the craniocervical junction. And then one can translate the cervical spine forward as compared to the skull base, since the patient's head is fixed in the Mayfield head fixator, by translating this rod that's attached to the cervical spine and connected. So we do really two-step maneuver here in the OR. One is distractive force at the craniocervical junction to disengage the dens from the foramen magnum, and then translate the cervical spine anteriorly with respect to the skull base by taking advantage of this rod and pushing the cervical spine forward and realigning the spinal column. And you can see that now we very nicely realigned the spinal column and did the occipital fixation here. You may have noted that we haven't touched the tumor, which is sitting up here in the front. We did a laminectomy here, which offers some indirect decompression, but the main purpose of this was really to monitor what we did during the surgical reduction using an intraoperative ultrasound. And then we go ahead and treat the remainder of the tumor with stereotactic surgery. And so we achieve all the objectives here. The patient's deformity was corrected, the spinal cord was decompressed, and the stereotactic surgery took care of the patient's ventral tumor that was situated in the dens. Here, this patient lived another 4 or 5 years and eventually died of metastatic disease. And this is another patient who has a bit of a different problem. This is an older lady in her late 70s, has a lung cancer that was deemed inoperable. The patient received radiation and chemo for her lung cancer, but couldn't tolerate the chemo very well. Presented with severe interscapular pain and lower extremity weakness. And you can see T3 vertebral body collapse with spinal cord compression here. So this is a very fragile old lady with inoperable lung cancer. And so we took advantage of the minimum invasive techniques here that were developed for really mainly for degenerative spinal disorders. But we have two we'll see the approaches here, one on the right, one on the left, using tubular retractors. We can, do this operation through the tube in a circumferential manner. As you can see, the spinal cord was decompressed, the nerve was tied. We reconstructed the anterior column through the tube with a cage, fenestrated cage, as you can see here. And then percutaneous screws are implanted to stabilize the spine. And this is the patient's back, how it looks like, with a number of stab wounds and the approach-related incisions. And the patient has the drain here. We were planning to do this open approach if this didn't really work, but we didn't have to do that. And of course, this patient now avoided not only major revascularization of the soft tissue around the spinal column, but also could go to radiation treatment after that relatively quickly. And so this patient got discharged several days after surgery with significantly improved pain and restoration of neurological function. So this was a reasonable option for this patient. Let's look at this one here. This is a patient who has a very large upper cervical spinal tumor involving C234. This patient has presented with swallowing difficulty. Exams show the mass in the back of the throat. The patient had a CT-guided biopsy of this. This proved to be a chordoma. And, this is it's best to resect this tumor completely. This is really bad news for this patient, as you can imagine. Cannot really give a lot of radiation given the situation here with the spinal cord. And so we designed a very big operation for this patient. Here's the patient's head is on the right side, the thoracic spine is on the left side. Here is the area of interest in the middle. And now we did a multi-level laminectomy. As you can see here, we dissected out the vertebral arteries on both sides. This is the left one, this proximal right and proximal distal right vertebral artery. These are the C2, C3, C4 nerve roots. You can see the tumor coming through here. So we're gonna try to remove this tumor in one piece. So of course, and then we typically dissect out the tumor and put this elastic sheet ventral to the thecal sac to separate it from the tumor. So when we come from the front to extract the tumor, we know what the surgical plane look like. And then we do a long instrumentation here. This slide is pretty old, I think about at least 20 years old. And you can see we didn't have a lot of options at the time. And so we had to use wires and stuff to be able to put this together. And the second operation was done through a transmandibular circumglossal approach to the head neck region. As you can see here, this is the type of exposure that we'd like to get here with this type of approach. And this is what it looks like in the OR. This is the trichinoesophagus. This is the edge of the mandible. The nose will be up here. This is the right side of the neck is exposed. This is the carotid, and bifurcation is up here. Here's the vagus coming down. Here is the IJ. And we are reflecting the trichinoesophagus from right to left. And you can see the tumor mass. You see this has been disconnected completely, except for the top and the bottom. And we cannot really get to the top of the tumor here. You can see that, it's out of our view. The bottom is easily accessible. So then we go ahead and split the mandible. When we split the mandible, you can get very nice access to the back of the throat here. We are way above the vessels, and then you can disconnect the top and then connect this here. The tumor sitting is right here. And then extract it. When you extract it, here is the situation when we are looking through the mouth of the patient, the ventral dura. These are the nerves that were cut from posteriorly on the right side, and you can see the left side of vertebral artery that's preserved, and here's the close-up view of the carotid. Of course, we need to reconstruct this. As you can see here, we did that with a cage, which was cut a little taller here to function also as a plate. So we then embedded screws into the vertebral bodies above envelope to put this together. And this is the artist illustration when we published this many years ago, showing how this is really reconstructed. And then finally, here's a specimen that was removed in one piece. And here is the how it correlates to the MRI image. Even this little subtle little change you can see in this vertebra has got tumor in it. And so, and this was resected in one piece, and margins were negative on this patient. This is another tumor which looks similar. I would argue this was probably the most technically demanding operation I did in my career. This was a 24-year-old boy who from Israel originally. Presented to the physicians over there with quite a paresis, was taken emergently to the operating room. They did a laminectomy in the back. You can see the little biopsy that they did here. The diagnosis came back as epithelioid sarcoma, and the patient was sent to medical oncology and radiation oncology for the rest of the treatment. And they said there's nothing we can do to this patient until this tumor is taken out. At least most of it is taken out. And then I was communicating with the patient's mother. And then one day I get a call from the emergency room, really a couple of days later, and they said, your patient from Israel is here in the emergency room. And sure enough, we are having this discussion with the mother, and here's the axial images. You can see the tumor extends not only into the spinal canal, but also into the dura. And this is the spinal cord in the middle, sort of encircled by the mass that's coming through the dura. And so I told the patient's mother, and I said, I don't think that there's much I can do here. I mean, this kid, unfortunately, is going to progress to quadriplegia and die. And she said, please do whatever you can. And so we went into this operation by planning a two-stage surgical procedure. And we started from the back. We have a big hockey stick incision here, the multi-level laminectomy is open the dura, expose the spinal cord. The tumor had come through the dura, and fortunately, we were able to separate it from the spinal cord. You can see this tongue of tumor that sort of encircled the cord here. We were able to untangle this from the spinal cord. And then the key to this operation was really to get access to the contralateral pedicles. You can see that. And so we then went ahead here to close-up view of the mass. We opened the dura, and this sort of untangle this one, and then we're going to go ahead and cut the contralateral pedicles with the bone scalpel, as you can see here, between the nerve roots. This allowed us to now mobilize the specimen quite a bit. We were able to get around this laterally here. We took the vertebral artery, of course, on this side, and C2, C3, C4 nerve roots on this side. And then we were able to gain access to the ventral dura, and then cut the dura all from posteriorly. It's amazing what kind of a corridor you can get when you get the vertebral artery and the nerve roots out of the way. And all of a sudden, everything sort of opens up in that area. And then we were able to dissect this all out from posterior and extracted the tumor. And you can see this came out in one piece. And here's a spinal canal where the spinal cord used to be. Here's a tongue of tumor that we unpeeled. This is the edge of the dura that we cut and left behind. And this is the CT scan after the surgical procedure. And this is all done from posteriorly, and we are missing entire cervical spine, anywhere from C1 all the way down to, I think, the mid C5. And then we had to reconstruct this area. And so this is a mechanically interesting part of the spine where, you know, the weight is transmitted from the occipital condyle down, and not from occiput down to the tip of the dens, right? So we had to reconstruct that. And so we put a cervical lateral mass cage here. And then I used these Folds lateral mass screws that were embedded into the cage. And then we connected everything to the posterior construct with multiple pedicle screws in the thoracic spine. And here's in the order that how it looks like. And you can see the reconstruction of the dura here. Took 3 patches to be able to do that. And here's the cage and the screws that are embedded into it. This is the patient's post-op MRI scan. You can see I have a fairly sizable pseudomeningocele here. And our chief resident was very concerned about this. He called me, but the patient was swallowing, breathing fine. And there's no CSF leak to the outside. And I said, we're not going to do anything about it. Then eventually it was resolved. We didn't have to do anything about it. And this is the patient's immediate CT scan. And here is the patient's reconstruction images here. I did not really have a lot of faith in this operation when I went into the operating room. I didn't think that I was going to be able to do much. At the end, we were able to get this tumor out completely. This patient subsequently had stereotactic surgery as well as 6 courses of sarcoma chemotherapy at Sloan Kettering. This patient is almost 9 years out now. I think is still alive, no evidence of recurrence. And this patient since then got married and has 2nd child just this past year. And I get pictures from Israel from his mom, and she was ecstatic that he went on to have a family and had a child. So it goes to show you sometimes you go in there with not so hope, but at the end it all worked out. This is another patient, just to show you some of the more recent things that we have been doing in treating these tumors. This is a physician, emergency room physician, presented with right arm numbness, tingling, some hand weakness, and then soon afterwards developed the Horner's on the right side. And so he thought that he had a Spear sulcus tumor himself, and got the imaging done, and this tumor was noted. Had a CT-guided biopsy of this. This proved to be a chordoma. And so we did a 3-dimensional printed model of this tumor. You can see from plastic, multiply colored, showing the extent of the tumor, how this tumor relates to other critical anatomical structures. And then we use that in the operating room as a guide. It really is extremely helpful rather than going back and forth looking at the MRI scan. And you can actually turn the tumor around, and you can just one of our actually undergrad students, Owen, who's been leading this project. And it's very helpful. This is my thoracic surgeon who was helping us with the exposure from anteriorly. And he was saying that, it was going very gingerly here. I told him, why are you moving so slowly? And he said, I'm concerned about the subclavian. And I said, subclavian is about 1.5 inches away from us. He said, how do you know that? And I said, look at the model. We are not even close to it. And here's the patient's intraoperative images. Here's the neck dissection. We're going to do a trapdoor exposure here. This is the first stage of the operation. We came from the front here, and then open this up. And more importantly, this is our intraoperative image. You can see we have an image, the navigation frame here, and here's the tumor. It's an intraoperative CT scan when the patient's chest is open. And so we can see exactly where the tumor is, and you can see we sort of mapped it out on the patient's chest X-ray there, which is an intraoperative Scott image from the CT. And then you can see using image-guided navigation, we're able to cut these vertebral bodies very precisely from ventrally. And then came back from the back. Here's a patient's upper cervical spine, the thoracic spine, midline, left shoulder here, the right shoulder here, and we were able to extract this from the right side of the chest. And here's the specimen that came out in one piece. And here's the patient's intraoperative CT reconstruction images showing the parts of the spine and the ribs are missing where the tumor was resected. And this is a ghost image of the hardware and how it was sort of assembled together. Now, of course, we've been taking advantage of the image-guided navigation in the OR extensively. This is another case of mine that has a thoracolumbar spine, all of these from Brown, actually. And so this patient had a 3-level lesion with significant size mass, chordoma, on a CT guided biopsy. So you can see that I can get the patient into the OR. We have an intraoperative CT scanner. We can image the patient. We register the patient to the computer, and then we get the patient's MRI scan that was on pre-op and fuse them. And then now we have a map of the tumor in the operating room based on the image-guided navigation. We can then navigate. Here's the patient's CT scan on the right side and 3D printed model as well. But more importantly, in the operating room, you can see how we are knowing exactly where we are. I can drill this down pedicle all the way to here. I know what's in front of the spine. And so we can do this very, very precise. This is in the operating room. This is the second stage of the operation. We opened up both the back and the side to be able to deliver this tumor. You can see close-up image of this tumor. It's a massive size mass, and it's going to come out with 3 additional vertebral bodies. And then we extract this through the chest, and you can see the mass from the chest, how it looks like. And then eventually we were able to remove this, cut several thoracic roots here, and then reconstructed this area with the rods, as you can see here. And this is the post-reconstruction image on the right side. Again, this was removed in one piece. And then this is the final case I'm going to show you. This is a lumbosacral chordoma. Again, a 3-level disease, mainly from 4, but also involving the 3 and 5 here. So we approach this in 2 stages. First, from posteriorly, multi-level laminectomies. We dissect the nerve roots out all the way into the retroperineal space bilaterally. Here's the construct from the lower thoracic spine all the way down to the pelvis here, as you can see. Here's in the intraoperative picture. The patient's head is on the left side and the feet are on the right side. This is the area of interest. You can see the nerves are widely dissected. A couple of wires you can see here. There's wire here. I don't know if you can notice that. That's a Tomita thread wire saw. And this is something we're going to retrieve from the front to cut the spine. And the other 2 wires that are over the rod, those are going to be used also to secure the cage in the front. So we plan for this in advance and put the ends of the wire on the paraspinal area so we can extract them from the front. Here's the second stage of the operation that's done through a midline approach here. And then we get the ends of the Tomita thread wire saws and then use that to section the spinal column precisely. And then we place the cage, as you can see here, to make up for the defect after the tumor is removed. And then we use the wires that are encircling around the rods to secure the cage in place. And here's a specimen that's removed in one piece. Here's in the intraoperative picture during the second stage. The head of the patient is the left top corner. The feet are on the right side, the lower down. Here's the patient's S1 end plate. Here's the cage. You can see the wire that's encircling the cage anteriorly. This is the aortic bifurcation here. And here's how it looks like on a plain X-ray on AP and lateral views. You can see this missing part of the 3 vertebrae is reconstructed with a distractible cage. We have a screw embedded in the vertebral body, which prevent the kick out. And then you can see this wire that's encircling the cage so that cage can be kept anchored to the posterior construct. And of course, double rodding and all that, we do that, given that this area will be extremely challenging to fuse across. And here's a specimen how that compares to the patient's MRI scan that's removed in one piece. This was an engineer who presented with back pain. I don't pretend that I'm going to be able to cure chordomas with just surgery. And so we've been doing a lot of work trying to understand the biology of these tumors. Early on at Hopkins, collaborating with Alfredo Quiñones, we looked at brachyuria. As you know, brachyuria is a marker for chordoma on pathological specimens, a pathognomonic marker, so to speak. And about more importantly, brachyuria is a transcription factor that is encoded by the T-box gene. And this particular transcription factor is really the driver for the chordomas. Let me go back here. In the familial forms, there is duplication of this gene in a certain percentage of the families. And we do know that in all the chordomas, brachyuria is highly expressed, except for maybe the poorly differentiated and the differentiated chordomas. So this is the early attempts we did. Wesley Sue was one of our residents at Hopkins. We worked on developing a cell line for this. This is the cell line we developed from one of my patients. It looks like we made 7 attempts, and eventually Johns Hopkins cell line 7 was successfully engineered. And we implanted that in nude mice. As you can see, they are growing here. And then the tumor does express brachyury, just like the parent tumor does, all these xenograft models. And then we went ahead and used a small RNA in a cell culture, you can see here on the right side, and then we can block the expression of the brachyury in a cell culture. And you can see when you do that, or you can block the activity of the brachyury in the cell culture. When you do that using a small RNA, you can really block the growth of the tumor. And so this is sort of proof of concept where if you, A, the brachyury is highly expressed in chordoma patients, and B, if you were to block the activity of the brachyury with small RNA, you can really stop the growth of the tumor. Of course, the things are not so simple, but nevertheless, it all comes down to the brachyury. These are a variety of surface receptors that are expressed in chordomas, PDGFR, EGFR, c-MET, or fibroblast growth factor receptor. All of these are expressed in a certain percentage of the chordomas. And you can see through a variety of pathways, all of them really actually end up coming down to brachyury, and the brachyury becomes a major driver for the tumor. And so a lot of drugs have been tried for this, as you can see here. We also have some cell cycle inhibitors. We do know that CD4, CDK pathway in regulating the cell cycle can also chordomas. There are some vaccine trials. These are vaccines that are targeting the brachyury. These are some of the surface receptors that are being targeted. CDK, of course, is a cell cycle regulator, and then a checkpoint inhibitors more recently is being tried for chordomas. And this is a study that we did with Chetan Betagawa, looked at single nucleotide pleomorphism in chordomas, and we noted that if they don't have that, which is really substitution of one single nucleotide, as you can see here, if they are missing if they don't have single nucleotide pleomorphism, the majority of the people do, those patients do very poorly. You can see that all of the patients were dead in 6 years, whereas if they had the pleomorphism, they have been living for a long time. And then we also looked at the TERT mutation, telomerase reverse transcriptase promoter region mutations in these patients. I'm not going to bore you with the details, but again, if they didn't have the mutation, they start dying pretty quickly. And if they did have the mutation, they've been living for a long time. So these may be some of the markers that one can use to put the chordoma patients based on the molecular profiling into high risk and low risk categories. And you can see the presence of mutation denoted that the patient is alive at 10 years, 100% of them, whereas absence of the mutation indicated that some of them died much sooner. So in conclusion, I hope that I was able to convince you that understanding of the biology of spinal tumors is really very critical in defining not only the appropriate surgical procedure, but also prescribing the appropriate treatment for the patient as a whole. And block resection of the primary spinal tumors, particularly chordomas and chondrosarcomas, leads to a significant improvement in survival. And finally, I'm fortunate to say that the recent advances in surgical approaches, resection techniques, and spinal instrumentation now allow us to resect these tumors effectively, safely in most patients. Many people have contributed to the work that we have done over the years. These are some of the fellows and the residents who worked with me over the years. So these are from my MD Anderson years. Dr. Larry Wyans is now leading the program there. If you look at my Johns Hopkins fellows, many of them are leading their own programs. Michelle is, for example, at Mayo Clinic. Jean-Paul is Northwestern. Ali is at Hopkins. Patrick is at USC. John Chi is at Brigham. And let me see who also I have here. Reza Yassar is at Albert Einstein. Ilya was at Sloan Kettering and just moved to NYU. And these are, again, Atman is at Stanford. Ali is at the University of Pennsylvania. And these are some of the, what I would call enfolded fellows that we spent 2 years with us doing a lot of this work. Carlos is leading the spine program at Southwestern. Then just became the chair of Northwell in New York. Maury is at Hopkins. Larry was just moved from Hopkins, and Ben is at Mayo Clinic. And these are our Brown Fellows. Over the last 6 years, we graduated all these people. I hired three of them. This is one of our faculty. These two just we hired last year, Tim and Joaquin. And these various people are in various other locations. So Michael is leading the program in Syracuse, New York now with their spine program. These are some of the residents that I work very closely with. Dean Chow is at UCSF, as you know. Amir is the chief of surgery at Shriners in Philadelphia. Phil is the chief of pediatric surgery at UPenn. Matt is the chair of neurosurgery at Northwestern, and these are my bosses or mentors over the years. Dr. Robert Grossman was my residency, of course, my chair and residency program director. That's why is my first boss at UTMD Anderson Cancer Center. Dr. Bram is my second boss at, of course, at Johns Hopkins. And so I was trained by Cole Cooper, did my fellowship at NYU with him, and Gordon Engel and Tom Berg are two orthopedic surgeons that I worked with closely. But Dr. Gordon Engel at the time was the president of the Scoliosis Research Society. With that, I just want to thank you all for listening to my talk, and be glad to answer any questions you might have.
Hi, Ziya. This is Ajit Thomas here. I just want to congratulate you on the amazing technical skills involved in these surgeries. I'm just curious. I noticed that you have to put a lot of hardware, and the question I had was, is there a high risk of the hardware failing because a lot of these are cancer patients and the bone graft may not really take at some point?
That's a great question, and the short answer is yes, of course, we are very concerned about that. So we use a number of different strategies to minimize that risk. It's number one, as you have seen, in many cases, we have been using double rodding of the construct. So typically we would put not just one rod, but two rods. And we are always prepared that the patient is not going to fuse. So we really try to effectively reconstruct the patient with metal, but in many cases, it will be 160, 360 reconstruction. So we will be anterior construct, posterior construct, and most of the time they are connected to each other. Number three, if the bone is not really suitable for screw placement and too soft due to osteoporosis, we typically augment that with cement. And then finally, despite that, sometimes we get the rod breakages. And if they break, I go and replace the rod.
Very nice. Thank you.
You're welcome.
Hey, Ziya, this is Raphael. I just wanted to ask you a quick question about, let's say, segmental metastatic disease that you would want to approach via separation surgery. Yeah. So let's say you have a lesion like at T3 or T4, and then you have something else down at like L3, L4, both requiring, constructs that might not necessarily need to be connected, if you will. Do you approach that? Do you do like segmental, instrumentation in these two different areas if need be? Or
yes,
you always
yes, absolutely. I mean, I think that we would treat every area individually, every segment that requires treatment individually, unless the instrumentation sites are pretty close to each other. If there is at least two healthy discs in between, I don't necessarily connect them. If I have only one disc left between the construct above and below, then I typically connect the rods and make one big construct. Because if you leave only one segment, one motion segment in between, that typically breaks down pretty quickly. You end up going back and revising your surgical procedure. If they are far apart, then I treat them totally independently of each other.
Very nice. The other question I have for you is, how closely do you work with the radiation oncologist? So in other words, I know that do you have like a tumor board that you have with them separately?
Yes.
Are they fairly aggressive?
Yeah, so we have typically, really, to be honest with you, it becomes like a virtual tumor board. All of the patients are seen by radiation oncology, and we see the patients and we then talk, usually virtually, and say, here is the situation, what would you like to do, and so forth, and then we plan accordingly. And so, and then we, most of the time for patients that require separation surgery, that decision is made jointly. And so we are planning for radiation already before we go to the operating room.
Yeah, that was a fantastic. Oh, go ahead, Eric, please.
Okay. Thanks. Ziya, this is Eric Wong. I have a medical question, And since the introduction of checkpoint inhibitors, I have not seen that many spinal metastases. And it led me to wonder whether or not the spinal column is a thermostat of how healthy the patient's immune system is, because as you know, 25% of the bone marrow is in the spine. And I'm just wondering, where among those patients who you operated on with one level disease versus oligo level diseases, do they respond to immune therapy differently when medical oncologists give them checkpoint inhibitors?
I think the short answer that I don't know the answer to that. It's a very interesting observation that from your end to see whether or not, I mean, we always believe that the metastatic disease in the bone is a late manifestation of the process. And so maybe the patient's immune system has already been overrun by the neoplastic process. And I don't really have a good sense, since I don't see all these patients that are on checkpoint inhibitors and see what percentage of them actually develop metastases. Very few patients that I operate on, maybe it's a very interesting observation, that are actually on checkpoint inhibitors. Very few of them are. And so maybe if you get them onto that before they develop spinal metastases, you may be protecting them. And I'm just trying to determine to see in my mind how often we put the patients on checkpoint inhibitors. After that, that's completely deferred to the medical oncology the discretion. So I don't really know the answer to that, but it is a very interesting question. I think that it's worth looking into that very critically. We have a fair number of patients collected already in our database, so we can certainly try to answer that question. I don't know the answer.
Thank you.
Hi, Dr. Gokaslan, Justin Massengale. Nice to see you again. I have a question. Hello. Hi. Oh.
Hi, Justin.
Hey.
Go ahead, Justin.
Thanks. So I have a question about small cell lung cancer, metastatic small cell lung cancer, and how it is typically considered to be very, very radiosensitive. Does the principles of the separation surgery still apply for a patient, say a thoracic small cell vertebral body met with some spinal cord contact, or is the fact that the sensitivity of the tumor is so high mean that perhaps less radiation would be necessary, and therefore the risk of spinal cord injury from the radiation of spinal cord infection radiation wouldn't be as high, and therefore the separation surgery is not as not as crucial? What are your thoughts about the consensus on that?
I think the latter is the way that we approach it, in that even if the patient has significant spinal cord compression, but neurologically not at the verge of becoming paraplegic or quadriplegic, we try to get the patient to radiation as quickly as we can. These are sort of urgent radiation consultations for us. This is true for lymphomas. I don't know if I have any radiation oncology colleagues on the line, but the only patient that I don't get any resistance from radiation oncologists coming on a weekend and seeing a patient are the lymphoma patients and the small cell C of the patient. So those patients go to radiation very quickly and they respond dramatically. And now one caveat is that with multiple myelomas, for example, we have been seeing much more resistant disease now, particularly for patients that have been extensively treated previously. And so they got their bone marrow transplant, they've gone through multiple courses of various multiple myeloma regimens, and then they get a recurrence and they get radiated, and then they get a recurrence again. And they get that second recurrence, that tumor becomes almost like a non-multiple myeloma type of tumor that we deal with. It becomes much more surgical, and we are forced to operate on those patients. De novo presentation, multiple myeloma in the spine, or small cell C of the lung in the spine, or a lymphoma for that matter, we almost never operate on them except for biopsy or diagnosis.
Thank you.
You're welcome.
I really enjoyed your talk. This is Martina Stuckler. I have a question about you.
about the decision making when to operate. I really loved how you laid out your systemic approach with metastatic disease. But sometimes we come in kind of at the end, widely metastatic disease, some organ failure, coagulopathy, and just because we can, should be. So what is your North Star when you say, this is just too much for me to operate on? Or do you say, even palliative, whatever, I just gonna operate because I have the ability to do it? What is your North Star? How do you guide this conversation with medicine?
Yeah, it's a very appropriate question. And there are many patients, unfortunately, who are at the end of the road. And then they also have, spinal cord or spinal column issues that may benefit potentially from surgical procedure. But in those cases, we really talk to our medical oncologists, and many of these decisions are really made together. Just to give you an example, about a month ago, we had a patient with esophageal cancer whom I had operated on already twice, one in the cervical spine, one in the lumbar spine, two separate diseases, and the patient had been on systemic chemo for his esophageal cancer. A triathlon athlete, very healthy otherwise, got this disease, got the progressive deterioration, 40 years old, 2 kids, beautiful family, and we are stuck now to develop a third lesion in the thoracic spine with horrific looking circumferential spinal cord compression and the progressive lung mets and whatnot. And so, although the patient looks relatively fit, we came to the conclusion that we had lost the battle in this. And we decided, we talked to the family and we made the decision that we would not offer any treatment in hospice and to send the patient home. And the patient died literally about 4 weeks later. And so coming back to your question, there are patients who may be surgical candidates, but we would not necessarily offer surgical treatment to them. But one caveat is that it really depends on what you're going to offer to them. Sometimes even the patient who's at the end of the road, let's say, has a pathological fracture, and I can do a percutaneous vertebroplasty or kyphoplasty and take care of the patient's pain and send the patient to hospice to die, I would consider that, because that patient would go comfortably and spend, the last several weeks of their life with the family. Whereas if that same patient requires an open surgical procedure and is going to end up staying in the hospital for the remaining weeks of his life, then we would not really consider that. But again, I think, we would work very closely to our medical oncology colleagues to make that decision jointly. I don't know if I answered your question.
Yes, you did. Thank you very much.
Certainly, that's a tough area. If there aren't any other questions, this has generated a lot of interest, a lot of discussion. I think people are texting each other a lot of questions as well. But I also have to thank Ziya, because I don't know if others realize, he's actually at a spine meeting in California. So he got up at 4:30 in the morning to give this talk. So we are quite appreciative of your efforts. And thank you very much for the lecture. It was extremely informative. And I think we'll probably have some discussion later on today. But I think I'll close the session. But thank you very much for taking the time to do this. And we'll follow up with you by email as well.
All right. I think that's the end of the session today for me. Is that you don't have anything else scheduled for me? Is that correct?
That is all we have scheduled. But thanks very much for taking the time to do it.
You're very welcome. And thanks for the opportunity to meet all of you, albeit virtually, and hopefully next time we can do it in person. Thank you so much. Bye-bye.
Thank you, Ziya. Bye-bye.